but not very long.
And we are live, Senators.
All right, good morning. This is Senate Health and Welfare. It is Friday, April 14th. We are hearing testimony on H473, an act relating to radiologic assistance. And then we'll move on to other bills. So why don't we get started? First, Jen, we have been through the bill, so we won't go through it again.
Great.
But we do have Jessa Barnard here from the Vermont Medical Society. Jessa, do you want to start in? Or, I mean, I see that Mary Streeter is here as well as Kristen, and maybe we should start with them since they're maybe at their work site. So let's start with Kristen. Just how do you pronounce your last name, Kristen?
Disticker.
Disticker. Thank you. Welcome. And why don't you please, this is our committee. We'll introduce ourselves once for folks, and then we'll have you introduce yourself for the record. So Senator Buick.
Oh, hello, Senator Martine LaRocque-Ulick from the Chittenden Central District.
Good morning, Dave Weeks from Proctor, representing Rutland County.
Senator Ginny Lyons, Chittenden Southeast.
Senator Terry Williams, Rutland District.
Good morning, I'm Ruth Hardy from the Addison District.
All right, welcome. So we look forward to your testimony.
Sure. We'll do a quick round of introductions as well. I'm Kristen Disticker. I'm the professor and chair of radiology at the University of Vermont and the healthcare service leader for the University of Vermont Health Network Radiology Department. And with me today, I have Mary Streeter. And Mary, did you want to do a quick introduction?
Hi, good morning, everyone. Yes, my name is Mary Streeter. I am a radiologist assistant at the University of Vermont Medical Center. Thanks for having us here today.
Thank you.
Thanks for being here.
So I'll just launch this, and then I'm actually going to have Mary, give most of the testimony. But I think that we're living in a nation where we have a national shortage of radiologists and radiology technologists. And everybody thought that artificial intelligence was going to be the savior and come to rescue us and offer efficiencies in our workflows, but that just isn't happening fast enough. And so, for example, at the medical center and in the health network, we have 8 open subspecialty radiologist positions, which is about a third of our workforce. And many of those positions have been open for over 3 years. We also have at Porter Medical Center 3 radiologists that cover that service that will all be retiring within the next 2 years, with no real line of sight of how we're going to fill those positions. We have many patients already waiting weeks or months for basic radiology services that delay their diagnosis and treatment. And so we're thinking of other options that we have that we can put in place that are very low-hanging fruit options that would help us to meet the needs of our community and improve access to our patients. And that includes task shifting to advanced practice providers and physician extenders in radiology, something that we've already been doing since 2011, but for which we're asking a slight modification in the rule so that we could better serve the patients in the rural state of Vermont. And so, Mary, I'm going to let you take over at this point.
Okay. I'm not sure if I need to do a little bit of introduction about the role of the radiologist assistant. Would that be helpful?
Yes, go ahead, please.
Yeah. So a training for a radiologist assistant is much like a PA, but very specific to radiology. And so we come out with the ability to do image-guided procedures, to do diagnostic studies, but it's very specifically under the guidance of a radiologist. I couldn't go work for a urologist, for example. And so really the idea, right, is for us to do the things, as Kristen said. A lot of my work is around doing needle placement for people that are having pain injections or having MRIs that needed dye injections prior to that. And so when we speak to the levels of supervision, this is something I'm able to do, and the radiologist has to come with the current way the statute is. They have to come down to the room, they really look at the monitor to look at my needle placement, say it looks good, and then go back to wherever they're then reading out. So it allows them to read their higher end images or do studies at the highest end of their license while I'm doing things that need some supervision, but what we're asking for is more of a remote supervision for those types of things. That and for like upper GIs, for fluoroscopy exams also, which has a pretty broad scope of practice already, but what we're proposing is that, there could be more remote viewing of those types of procedures. I am the only RA in the state currently. I have been an RA since 2012. I've been in radiology for 38 years though, and definitely see the role of the RA as we're sort of perched here to make a change that could help us meet the needs of the workforce that Kristen's speaking to a lot, so improving access, it's a more affordable delivery of care. And the quality is really, very high for RAs because they come out very specialized in the field of radiology.
Yeah,
So I very much support and would feel comfortable with, a radiologist being at a remote site or somewhere else while I perform an exam. I very rarely do I need to call on a radiologist to help me in that way. It would only be for like urgent, I think, medical issues, which is why we're proposing a physician on site may or may not be a radiologist.
And I'd
Thank
just
you.
like to add that having a radiology assistant to form the basic procedures in radiology allows for the subspecialty radiologist who's more of an expert to focus on the advanced imaging examinations and help to work down those backlogs, improve access for patients. And we firmly believe that the remote audiovisual supervision is more than adequate to allow us to be able to do that for the radiology assistants.
Thank you. Senator Gulick has a question.
Thank you for your testimony. This seems like such a great use of technology and exactly what we should be doing with the technological advances that we have. And I feel as though I will support this, and it seems to make total sense for me. Mary, you're extremely experienced in what you do. I'm wondering if there's ever a time with a new radiology assistant or a new person on the floor, if you would feel that they would actually benefit from the in-person guidance. So I'm just wondering if experience plays a part in this at all.
Well, I think, anyone coming out of RA school, I had about 11 years of schooling before I was done, right? Because it's like, first of all, you're a radiologic technologist first. Everyone's required to have that license. I'm dually licensed. So I had a bachelor's degree, went on and got my master's degree in radiologic sciences, and was required to have 5 years of experience prior to that. So anyone coming out of school is proficient in all of the exams that, and it's a certifying exam, national exam that we have to take and recertify every 10 years. So everyone's coming out having performed proficiently. What they would need is just to learn sort of the workflow, right, of any particular place. But you have to be able to perform these as everyone. It's one of your requirements. So I do feel like, of course, my experience helps in many ways, but anyone coming fresh out of school ought to be proficient in performing anything I currently am doing or that we would be wanting to be done throughout the network.
Great, thank you.
Yeah.
Thank you. I do have a question. Once you take the picture, get the photo, the x-ray or whatever, do you do preliminary interpretation, or do you simply look for accuracy of the x-ray or the picture that you're taking?
So our training is that we are able to, we're not ever in our practice able to communicate results to patients, But this is where I could definitely make a preliminary interpretation that I would share with the radiologist. We really say it's my observation is the word we like to use. But I definitely have been trained to look at images and understand what I'm seeing. I'm not just performing like a radiologic technologist, the acquiring of the images. I definitely can make judgment as I'm doing it that I might need more views, or obviously if I'm doing a needle placement, I have to be able to know how I am approaching that. So even though it's very strict in our statute that I am not to give preliminary results to patients, it's definitely a way I work with a radiologist, and then they finalize the report.
Okay, thank you.
Yeah.
Senator Williams.
Just a question, so we're talking about personnel shortages, and this would be as a stopgap until we can hire enough radiologists to do that?
No,
So
I
there's
actually
like-
see this as a strategic vision for the way forward in population health. You know, as we're trying to improve access and reduce total costs of care and maintain the quality of our services, this is exactly the type of role that we want to have in place going forward. And you know, what we're really asking is that we believe that the federal rules will change around the ability to use physician extenders, and that we don't want to be in a place where Vermont is more restrictive than the federal government once that happens. So this would set us up to be able to move in that direction.
So would your protocols have to change at all, or?
No, absolutely not. The only thing we would be adding would be the audiovisual supervision, which, you know, quite honestly, we became very proficient at during the pandemic. So this is, you know, this is going to be just an extension of what we know, and not really any new scope.
Thank you.
If I could, you just introduced the concept of physician extender, which I think I understand, but can you kind of round that out a little bit and explain?
Yeah, so a radiology assistant is an extender to a radiologist. A radiologist is a physician. And so as Mary explained, radiology assistant has an RT background. So she's a certified radiologic technologist. She has gotten a master's degree in radiologic sciences, which is required for an RA position, and then has done 5 additional years of training, including clinical service.
Chris,
And
I
so
heard all that. Just wondering, the concept of physician extender, is it just as simple as it sounds, that this is an enabler? Okay.
Yep, yep.
Yeah, my
It's
society
not-
is of radiology physician extenders. Yeah.
And it in no way implies that the radiology assistant is giving a final interpretation. It's just that they're extending the radiologist to be able to function at the top of their license so that we can take better care of patients.
Thank you.
Thank you. Any other questions, committee? Oh, thank you for being with us. If you could please send us a very short statement, your testimony, so that we have this, it would be extremely helpful. And then you can just send it along to Alex and we'll put it on our webpage.
Absolutely. Thank you so much for having us today.
Thank you.
Great, thank you.
Bye-bye.
Jessa. Bye-bye.
Good morning. Thank you for having me back again. Jessa Barnard with the Vermont Medical Society. We are in support of the concept of this bill. We do appreciate efforts to sort of modernize statutes around supervision and practice when we feel it is safe and appropriate. And we appreciate the Health Network reaching out to us early in this process and asking if we had any concerns or feedback. And I think they've really modified the language to be pretty specific for what we feel comfortable with. That said, since the bill passed the House, a question came up from some of our members, which we had not really thought through with the change around remote supervision, because we just sort of assumed that this was not a problem, but then we realized the language doesn't actually directly address it, which is does that supervising radiologist, even if they are remote, have to have some kind of nexus to the same facility, employer, practice site in Vermont? We understand they may not be, and actually the whole point of this modernization is that they don't have to be on site at the same location, but do they have to have any relationship to the facility or to the state of Vermont? Could they be, could you have 3 radiologists out of Utah remotely supervising radiology assistants in a number of states? And we don't think the current language fully addresses that problem. We've been trying our best to work with the Health Network, and Jen has stepped in. It's not quite as simple of a language solution as we thought, so I'm not sure we've landed quite on the right language, but I think everybody's comfortable with the intent of adding something that says the supervising radiologist needs to be have as either their employer or work site the same facility or an affiliate of that facility. So we don't want it to have to be the same facility, because that's the whole point of, maybe they're at UVM MC in Burlington and the radiology assistant is in Porter. We're completely comfortable with that scenario. It's just, we want some kind of nexus of the work site and employer.
It does make sense, but it also opens up the question around patient confidentiality and then where records are going, but right, rules.
I think because they would be either in the same place or with affiliated.
Well, no, I'm saying that the language that you're proposing sort of protects that patient confidentiality. But if you're sending it to Utah.
I think you could have all of those protections in place through a contractor relationship, if you wanted to. But we're more concerned about having that a closer relationship to make sure you really have the same kind of oversight and some kind of easy connection between the radiologist and radiologist.
So is this the language that you were connecting with David Hurley at the Board of Medical Practice about?
Yes, I just emailed him
Oh, good.
a few minutes ago to ask the.
Yeah, we probably don't need to spend a lot of time taking testimony on that. We can just get a good look at it and maybe have some improvement to the bill. That'd be good. Senator Brewer.
I have to ask a question. Is there a compact for radiologists, and could that play a role
Not
in
yet.
this?
I don't think we have a.
I think it's,
No, this is the radiology bill here.
So radiologists are MDs or DOs, so they are through the Interstate Medical Licensing Compact.
The medical assistant, so I thought you were talking.
But the
about-
radiology assistants, I don't believe there's a compact for, as far as I am aware. But there is actually, this is not as far-fetched of a scenario as you might think, where there is actually already a lot of remote radiology reading, and using contractors or others to read exams remotely. So that is it is not as far-fetched of a reality that you could then see supervision being remote as well. So we just want to.
Right, and if you're, you could be hired as a consultant from out of state. My husband's done that many times.
Right.
Yeah, correct.
Okay. Yeah.
Okay.
Excuse me, I understand your concern. What about the scenario where UVM Medical Center may be the only place that has sufficient staff, and there's a hospital that's not affiliated with UVM that wants to work with UVM to, like Central, I'm trying to think of another, like any of the hospitals that aren't a UVM affiliate might want to contract with them to do that.
That's, it's a good, legitimate question.
It is a legitimate question. I think, not sure I have a complete answer to that, except that it's pretty hard to, because we also, let me just back up for a second. We also don't want to say that the supervising radiologist has to be located in state, because there could be scenarios where, for example, Dartmouth might have the radiologist supervising somebody at Mount Ascutney, or, we need to allow, so
Is it just about licensure? Just a license?
it's not, can't be solved by licensure, because there are a lot of out-of-state physicians who have a Vermont license but still work entirely remotely.
Because of the compact?
Even just because of license, they can apply to have a Vermont license, and many do, even though they're based out of state. I think it's a little unique, I think in general, we are very comfortable with order, cross-facility practice. I think it's a little bit different when you're saying this is the supervising physician.
Mhm.
I do think that it makes sense for that to be a closer relationship.
Mhm.
This is not somebody practicing independently. They are under the supervision of a physician. And so I do understand the scenario of a different hospital, but I think at this point, I mean, and we could always come back and revisit this if it turns out that ends up being too restrictive. This is at least where our language has landed so far. And I think, given the small number currently, I think it would still allow a lot more flexibility than where we are right now, moving ahead with the bill, for sure. But I can.
No, I mean, it
there's
makes
another
sense,
way to-
because it's more than just, I think your point about supervising relationship is a good one. It's more than just reading the work of another person. It's actually providing guidance and supervision.
Right, and needing to be available and
For
for questions or emergencies or,
Lot to go. Yeah. Okay. Well, we will look forward to seeing some clarifying language.
Thank you. Yes, we're working our fastest. Thank
And I'm
you.
looking at
Thank you for your patience.
That's good. I think, yeah, but the issues are there. I mean, obviously,
Right.
in-state, out-of-state
Oh, right, I totally
connections.
forgot about that. Sorry,
No,
Jen.
what?
Sorry.
What?
We were just hearing the band outside.
Oh.
There's a
Yeah, we've been,
climate rally, youth climate rally.
okay, nobody's leaving. Sounds good.
Thank
All right,
you.
thank you
Thanks for your
very
time.
much. That's terrific. Jen, you want to say a couple words about how we're going to resolve that? And then we'll,
Sure.
I'm gonna go grab a bill. Does anybody want a copy
uh,
of this bill?
oh,
No.
I'm good. I've got it.
So again, Jen Carby, Legislative Council. So what we have been looking at to address what Jessa was talking about and looking at potentially amending would be first in section 1 of the bill, actually just pulling out that idea of readily available from the
Yeah.
definition of supervision and making it its own standalone definition in here, because then we would repeat it again later in the supervision and scope of practice section. So that's more of sort of a drafting thing. But then on where I'm looking at putting language would be on the second page in the second section in supervision and scope of practice, something to the effect as a new number 3, that the supervising radiologist and radiologist assistant shall be employed by and have as their primary work site the same Vermont healthcare facility or an affiliate of this facility, provided, however, that the supervising radiologist does not need to be physically present at the same location where the radiologist is practicing, as long as they or another radiologist, this is some of what we're trying to clarify with Board of Medical Practice, is readily available. So that's why we would make that definition apply across the chapter for consultation and intervention.
Okay.
So the clarification I'm trying to get is around this idea of a supervising radiologist. Who needs to be, is it that supervising radiologist that needs to be physically or needs to be readily available, or can it be a radiologist, which is what the existing language suggests, but it's unclear whether that's intended to refer to the supervising radiologist or not. And then there's primary supervising radiologist. So it's that whole set of potential supervisors or other radiologists that I want to clarify with Board of Medical Practice, so that we can make sure we're all on the same page as far as what is being proposed to you.
Okay, so far this makes sense. The question that Senator Hardy was asking about a hospital that doesn't have a radiologic assistant or radiologist, actually, they'll have to hire one, or they'll have to negotiate an agreement with a hospital that has someone, allow them to travel. And that's beyond this, that's outside of this scope of the bill, I think.
I'm not sure I fully
I know.
followed the, okay.
It's okay.
Question.
It's just an outside thought that was inside. Okay.
I have them all the time.
Huh?
I have them all the time.
I guess I don't understand why, if radiologists are already included in the compact, why they can't do this work remotely through the compact.
But this isn't just about the MD. This is not about the radiologist. It's about the assistant. So right now, the MD and the assistant have to be proximal or in the same facility. So with this proposal, the MD could be at UVM and the assistant could be functioning at Porter or Plattsburgh or any of or this one right here at Central Vermont. So it allows for greater access to the radiologic assistant.
So this is addressing the dearth of assistants, not necessarily the dearth of.
Yes.
Okay.
Yes,
Yes, so.
Gotcha.
yes,
Right.
because as I think you heard, you saw the one radiologist assistant in the
Oh my
state.
gosh.
I know she's the only one.
Unbelievable.
I know, it's amazing, it's amazing, and that's what raises the question, well, if she's the only one in the state, how do the other
So
folks,
can we
they
create?
have,
Compact?
they have text, they have radiologic
There
text.
isn't, I mean,
There doesn't exist.
There's a national.
right, and I think, you know, most of the work, as I understand it, that the radiologist assistant is doing is in the physical location where the patient is. So it doesn't necessarily work to have a compact where people from, that, you know, there isn't, you don't think a big market for telehealth for radiologist assistants because they're interacting with the patient
Yeah.
in person.
Remember, the radiologic
Yeah,
assistant
yeah.
isn't the only one taking pictures.
Right.
The tech, we probably were more familiar with the tech who says, stand here, I'll move over a little, and then takes the picture. And that person doesn't have the same level of background and experience that the radiologic assistant has.
Right.
The different levels.
I'm just thinking about the radiologist, you know, it's gonna add to his or her workload for sure. And
How?
responsibilities.
How?
Just if you got one radiologist on duty in 3 hospitals that are, is
Yeah.
it gonna change the standard of care?
I think under our existing statutes, the Board of Medical Practice determines the appropriate ratio kind of how many radiologist assistants a single radiologist can supervise.
It's like
so
PAs.
just looking for
And
the,
I'm thinking out loud too. I'm
No,
just thinking about being
Good,
that
no, it's good.
radiologist is gonna have his workload. or his
right, so the
workload.
number of radiologist assistants, this is current law, permitted to practice under the direction and supervision of a radiologist shall be determined by the board after review of the system of care delivery in which the supervising radiologist and radiologist assistants propose to practice. So it's up to the board of medical practice to be determining sort of the maximum that would be allowed for an individual radiologist to
Okay.
supervise. And then it may be up to wherever the radiologist is practicing to determine what makes sense given their workload.
And then there are also specialists who look at the x-rays after the radiologist or ask the radiologist to help them interpret. So it depends on your field of specialty.
Good.
Okay, all right. Any other questions for Jen?
So we'll keep working on the language.
Please, yeah.
Yeah,
Yeah, this doesn't seem like this one. This one actually improves access, I think, as Kristen was saying, or Mary was saying.
So is our stance that we want to be as broad as we possibly can be within reason as Jen is crafting the language? I mean, are we going to try to provide them with what they've asked for, I guess is what I'm saying. 'Cause
Yes, well, that's in the bill. What they've asked for is in the bill. What we're trying to do is to qualify, do they work for the same organization? And how expansive is that?
Okay.
right, and that's the piece, and I think, you know, that the 2 providers you just heard from are with the UVM Health Network, and Jason Williams is on here as well. Jason and Jessa and I, and now David Hurley here, are working on the language that would work for all of them to then bring to you, so you can work for you.
Great.
For Jessa, if I could,
Yeah, sure.
isn't it just a matter of contract? I mean, if they recognize that they need the MD level radiological expertise at a hospital, remote hospital, it's a big contract to have that access.
So Joseph Varner, Vermont Medical Society, our concern is that just addressing it through saying you're a contractor or even credentialed by the hospital doesn't necessarily address it, because you could be a contractor or credentialed and never set foot in the state of Vermont. You could be entirely remote, and so that's why the language is a little more nuanced, to try to make sure that that supervisor has some real footprint at the same facility or affiliate.
Accessible to the patient physically. Somehow.
But that was the whole point, that they're not accessible to the patient.
Well, there are times when it might be necessary, so you want to be able to manage the assistant, you want to be able to get into the room, into the hospital, be together at some point.
Right, and if I may follow up on that, it's not to say they don't have to be physically located at that same,
No.
it could be a different affiliate.
Yeah.
Right, so it could be, they could, like as Senator Lyons was saying, they could get, in Burlington while the radiology assistant is at Berlin or Porter.
Exactly.
We're trying to merge the two concepts, that you don't need to be physically there to supervise, that you do have to have some nexus to the same network.
So,
Okay.
just thinking, about Rutland,
Mhm.
we have our care network down there too. Is that gonna obviously affect them too?
If they had a radiologic assistant and a radiologist, then it would affect them. Then the radiologist could be at the hospital and the assistant could be over at the orthopedic clinic next door or, something else. Yeah, I have it. Okay. Any other questions? We'll keep looking at this. Thank you.
Yes.
I'm trying to bring us the
We're sort of
solution.
ping ponging, Katie and I, that's, you next, and then we
All right, we are on H 222 and Katie has been working hard with us. Do we have a new?
You do.
And you're gonna have to put it up on the screen because we haven't got Alex to print something out.
Oh,
for us,
okay, great. Is it three?
It has also been posted, senators.
but Good, yeah, thank you.
I'm trying to
We
log
can
on
print it
here.
out
so you know.
ourselves, I guess. That would be good.
Is it draft 3.3? Yes, that sounds right. It's on the website, you guys.
Did you got all my messages, right? Last night?
I did.
I felt like it went on.
Kept me on my
midnight.
toes. Okay, I'm logging into Zoom so I can share. That's 1 second. There we go.
You should be all set, Katie.
Thank you. Okay. Okay, I think we're there now. Success?
Yes, there it is.
Oh, good. Okay, oh, no, this is draft 4.1. Oh,
I have draft 3.3 up from the webpage.
They're both up there.
Oh, 4.1 is.
4.1 is below.
Thank
It's
you.
below it? Okay, good.
They're all there.
Okay,
Which one would you want for?
4.1,
Gotcha.
most recent version.
Where is it? 4 point?
Just keep going.
Keep going.
It's, there's three of those. There's 3.3, there's 3.9, and there's 4.1. Maybe you refresh.
I think I'm gonna have to refresh.
Yeah.
Oh, no.
Never doubt Alex. It's there.
I don't have it. Oh, I do have it. There it is.
There we go. Phew, okay.
Thank you.
So, Katie McGlynn, Office of Legislative Counsel. This is an amendment of the same amendment that we've been working on. So the new changes are highlighted in yellow. This continues to be instances of amendment. So the first instance we've already seen, this pertains to the regional stakeholder meeting, changing reference to the accountable health, accountable communities for health to just blueprint for health. And then in the second instance of amendment, we're striking out a whole section, the section on the manufacturer fee, and then there'll just be in your bill, just the words deleted there. And then in the third instance of amendments, section 6B, this is our section on opioid use disorder treatment system. And in subsection E, we would be making an amendment, so it would read the Department of Vermont Health Access or the department's pharmacy benefits manager shall not require a healthcare provider to document the patient's adverse reaction to a medication prior to prescribing an alternative medication for opioid use disorder to the patient.
Right, that was the one we looked at the other day.
Fourth, this is an amendment you looked at yesterday. This is making some changes to section 8B. For example, saying 24 milligrams or less of the preferred provider medication. There's a change in the effective date of this section, but that comes at the very end of this amendment.
And this, when we look at 8B, that was the question that Diva had, and it was really about the work that they've done and that they will continue to do, and the recommendations on moving that date out.
Yeah, I want to talk about that
9
date.
months.
I'm very concerned about that.
So we can have them come in, if we would like, but I'm also going to share with you their interest. They have worked, during the summer with the Drug Utilization Review Board and others to improve, to look at how this would play out. And now they've asked to have just a little time for implementation of that section for Medicaid.
Yeah, I saw their written testimony. I had
Yeah.
requested that they be here today, so I'm not sure why they're not here today.
Did you ask Alex?
I asked you in committee yesterday, but that's not just a little bit more time. That's 9 months of more time, and
Well, they had asked
people
for July.
are dying. And I understand that they need more time. We had already pushed it to September 1st. Now they're asking to come back to not have it in place until July 1st of 2024. That's an additional 10 months, actually. And I just think that is too much time, especially if they were working on it last summer. They knew this was coming. They should have been able to get this in place. People are dying.
So I think if you look at their testimony, they're talking about the different regulations for the hubs and greater oversight for complex individuals. So getting it in place is not, it won't be a simple task. We can ask them to clarify, we'll have them do that. And if Diva is listening in, Alex, can you reach out to Diva and ask them if they can show up on Zoom so that they can explain their testimony that they have?
I'll reach out to see if they're available now.
This
All right,
is a
thank
big
you.
change
Okay.
on the last day that we're trying to do this bill. And yesterday I expressed my concern about.
I heard you, Senator, thank you. Okay, so Katie, let's keep going and we'll come back to that one if we can get Diva.
Sure. Okay, so top of page 2 is the 5th instance of amendment. This pertains to the definition of recovery residents. And in the definition that's established, it uses the word tenants, and this amendment would change the word tenants to residents. In the 6th instance of amendment, we're adding the drug checking language that we spoke about yesterday. Section 11 hasn't changed. What has changed in section 12 is removing references to the health department. However, there is a new subsection that outlines the department's responsibilities. So on page 5, subsection H, in subdivision 1, the Department of Health shall publish guidance and provide technical assistance for any service provider choosing to implement drug checking services under this section. And in subdivision 2, the department shall coordinate the collection and dissemination of de-identified data relating to drug checking services to inform prevention and public health initiatives. Next is the 7th instance of amendment. This pertains
So
to,
just stop with the guidance and
Sure.
the technical assistance. So this was run by Department of Health. I'm looking at David England, and we're all good with that.
and this change has
Makes a
been
lot.
made to a shall.
Yeah.
Yeah, okay.
Okay, yeah, because the shell on the second one I felt was important.
Okay. Next, 7th instance of amendment, this is the opioid abatement language. So we had an amendment to the special fund itself. I've gone about amending it differently this time. So on subdivision, page 6, subdivision 2, the department shall include a spending plan informed by the recommendations of the committee to establish pursuant to 4772 of this subchapter as part of its annual budget submission. And once spending is approved from the opioid abatement special funds, the department shall request to have the funds released from the national funds.
Go ahead.
From a fiscal point.
Yes.
Approved by who?
Yeah.
Yeah, that's a good
too.
question.
Approved by the General Assembly.
Yeah, and is spending the right word? Isn't it? And once
Allocation.
funding is appropriated,
Allocation, yeah.
is appropriated is what we do.
Okay, once
Yeah, we should be consistent with the budget process.
spending. And spending.
I mean, what? Can I strike that from the record? David, I did say whom. The two ends.
Okay,
The spending is
noted.
appropriated.
I was like,
How will we say that, Jen? I mean, Katie.
Appropriated by the General Assembly. By the General Assembly. I could spell in English.
well, no, you're just trying to do it in front of everybody. I'm sorry. You're doing a great job. Unlike Nolan.
Once funding, funding, do you want the word funding, or once funding is appropriated from the by the General Assembly from the opioid abatement special fund.
Yeah. Once.
I don't know if I would say appropriate by the General Assembly, because the governor does approve it, right?
Yeah, I don't know. Is there a way to put the,
Sometimes it's included in the budget, passed in the budget, I don't know.
Well, it isn't being passed in the budget here, though. It's the-
Yeah, that was the whole.
why don't we just say approved through the budget process?
That was a problem, though.
Yeah.
We were trying to get away from that.
Oh, that
we
is the
still have
problem.
that
I
language in.
know, okay, well,
As
this is
part
the
of its
budget
annual
process.
budget submission.
Okay.
I got, so that's what the problem that Katie was trying to solve, that we then made more complicated by you asking by who.
Sorry to make it more complicated.
Okay, so because the guidance,
Senators, sorry to interrupt, but I do have Diva Commissioner coming onto the call now.
okay, good. Let's hold this thought. Let's let it just float up there for a minute and we'll go, Katie, if you take your screen down. then we'll
Oh, I'm
begin.
sorry.
No, you're good. And then we'll come back right here. We're on page 6 of the amendment and we'll bring Diva on. Thank you. Where is Diva?
Oh, she just disconnected.
Uh-oh,
She should be back in a moment.
okay. We have a little serenade this morning. But it's all electrical. I hope it's renewable electrical. There's Andrea. Okay. Andrea, are you there? Whoops.
I'm not sure what, I think there must be a problem with her connection.
All right, we'll try one more time. Just be patient. Huh?
So the president of the college system is on.
Sorry, that's an education
Oh.
committee issue.
This is the problem with being a senator.
Yeah,
That's
we're
what
all-
I should want. Everybody's in a different place. Okay, Andrea is connecting.
The music is louder.
Andrea, you're
Good
here.
morning, Madam Chair. I apologize. I don't know why my connection is not working out well today.
Well, we'll keep our fingers crossed that you can be here long enough to have a conversation about the section 8B that's in H222 and that we have talked about previously. You did send in a short testimony. I think it would be helpful for the committee to understand the reasoning behind the date change request that you have made.
Absolutely. Thank you for allowing me to join. For the record, Andrea Delabrie, Commissioner at the Department of Vermont Health Access. I think that the main reason that we are requesting a delayed date is we had conversations with the Department of Health, the Substance Use Disorder, Division of Substance Use Disorder, and we were all in agreement that due to the change in the nature of the removal of the X waiver, whereby more providers will be prescribing medication assisted treatment that wouldn't necessarily have as much experience with as other prescriptions, that it would be better overall to allow time for education, to put some policies and procedures in place, and just to allow for them to be able to take additional time to do that, and understanding that the hub and spoke system in Vermont is very well developed. And that is what happened when the hubs were established. I can't remember exactly when they were established, but they did take a number of months to kind of implement protocols and procedures. I do know that the DEA also is rolling out some framework for this kind of training. And I know that that's also a factor. So the groundwork has been laid, but I think it would be better for Vermonters. I think it'd be better for providers to be able to allow that additional time.
Okay, so, but I hear you saying that, but we also do have experience within the hub and spoke system, and there are providers already out in the community waiting to do this. And we also have with us the Vermont Medical Society here. So I'm wondering, have you communicated with them about providing education guidance around this new provision?
I think we would want to coordinate very closely with BMS as well. I think this change really kind of came about in the last few weeks. So we have done our legwork internally, but our next step obviously would be to be able to coordinate with the Vermont Medical Society and ensure that, you know, parity in the spokes is we did research it last year. The H728 at the time was vetoed. We still did our due diligence in terms of investigating whether parity with hubs and spokes with allowing prescriptions of 24 milligrams of buprenorphine without a prior authorization was feasible at the time. And we had that topic was brought to both our advisory boards, the Clinical Utilization Review Board and the Drug Utilization Review Board. And at the time, the recommendations were not to make a change, but the landscape has also changed. So I think that we recognize that this needs to happen. I also think that we want to be able to kind of do it in a thoughtful manner, or as thoughtful as we can in terms of education.
All right, Senator
That makes
Hardy.
sense?
Yes, it does. I mean, it does make sense. We're trying to move it as quickly as we can. So we need to understand.
Commissioner, I, with all due respect, this has been an issue that has been on the table for over a year, if not longer. And I understand that the bill was vetoed last year in part because you were not ready to move forward. But there are Vermonters dying from opioid overdoses every single day. And the hub and spoke system is not working. And there are providers who are waiting to be able to provide this kind of treatment. And you are delaying it. And I don't think that that is responsible And asking for an additional 10 months to do something that's been on the table and that you've already laid the groundwork for is not an appropriate response to an emergency in our state. We were able to turn around things extremely quickly during the pandemic to get to save lives. And this is the same type of an emergency. So tell me, how can you do this faster? How can you do it before July 1st of 2024? The bill right now has September 1st of 2023.
We
If
moved
you
it
need
to
more time,
March.
how fast can you do it? You need to be able to do it faster than July 1st of 2024. That
Senator,
is well over a year.
we did move it to March 2024, but that's still 9 months.
I think it says July 1st.
We changed it.
The amendment that you're looking at today has March 15th, 24.
Okay,
We did.
well, January 1st, 2024. There are medical providers that know how to do this. I've spoken to them in my community.
Senator Hardy, thank you for the feedback. First, if I could just circle back to your first comment, which was part of the reason that it was vetoed was because we weren't ready. I don't think that's accurate. We were asked to investigate the feasibility of parity in hubs, and I worked very closely with Representatives Whitman and Small on that bill. We came to agreement on that bill. And we had nothing to do with we're not ready is not accurate. What we found when we did the investigation on the feasibility was that there wasn't a reason to make a change at the time. And fast forward to today, where we have a new landscape change. The removal of the X waiver does open up opportunities for prescribers that aren't as familiar. I think that's fair. It's a fair statement. It's not that they can't, do it. It's that, are we being responsible with this? And that is, I do take that seriously. It's not about the money. It's about rolling this out in a way that is coordinated and thorough and thoughtful. And that was when I spoke with our folks at the Division of Substance Use, as well as the Department of Health, we're all in agreement, that we don't want to take any steps backward with what had happened, previously before Hubs and Spokes had evolved. We want to just make sure that we're trying to educate and put information out there for folks to have access to. March, I think March is okay. We can do that. It's, we asked for a year because, that's often what it takes, but we can do March. I'm comfortable with March.
You do January?
I'm sorry?
You do January 1st of 2024.
I'll have to talk, I would have to go back to the commissioner for the Department of Health and others, because that, when we spoke about it, that's what they were comfortable with. But I can get back to you.
David?
I wasn't in this discussion, so I can't speak to the commissioner. But I can get back to you.
Well, the bill, this is just
Okay.
incredibly frustrating.
We'll put this one on hold, that particular question. If you could, Andrea, get back to us ASAP.
I will.
See, there's a sense of urgency in this room around this bill.
I understand.
It's the date that's critical, to get this going forward.
Okay, I will respond hopefully in the next hour.
Perfect, that'd be great. All right, thank you. We'll finish going through the amendment and then we'll look for your information. Thank you.
Okay, all right, thank you.
Okay, so Katie, we were at wordsmithing stage on page 6.
Yes, I'll pull it back up. You left me unsupervised with my own thoughts, so I continue to edit.
I knew that was going on. That's good.
So here's where we are now. The department shall submit a spending plan to the General Assembly informed by the recommendations of the Opioid Settlement Advisory Committee established pursuant to section 470 4772 of this subchapter. And once funding is appropriated by the General Assembly from the opioid abatement special fund, the department shall request to have the funds formally released. I think that
We like that?
Yeah.
See,
Your thoughts
hastily
are good,
Vermont.
Kate. All right.
Yeah.
David wasn't in the room though.
Okay, well,
Okay.
that'll go in, that's great.
Okay, next is section 14. This is the actual appropriation from the special fund. So this language is all the same since you've last seen it, and you'll notice there's a conversation. This is this subdivision 8. There was a conversation yesterday about this drug checking language and where to appropriate it from. So it's still in the draft coming out of the opioid special fund. And then we have the 8th instance of amendment, which is the effective date that have been discussing. So this is where it is changed to March 15th, 2024.
Wait, can you repeat what you said before that?
Section 8.
Yes. So subdivision 8 on page 8. This is the drug testing language. It's the same language we looked at yesterday, but the committee had discussed where this money was coming from yesterday. And we had talked about the manufacturer fund. In the end, this language is coming out of the opioid fund. So I just wanted to be clear that that is still listed as it was yesterday.
Okay, and the question that we asked yesterday is we've taken a step beyond what was recommended by the opioid fund advisory committee, but the advisory committee did talk about this, and there was a concern expressed about immunity. That has already been put into the bill now in our amendment. And so the only concern that I have about that is that it's the first year that we're using the advisory committee process and the opioid fund. And then if in the first year we depart from the recommendation, that sets a precedent. So, and that's something we need to be very much aware of. Should we vote to do this? And I'm just opening that up for a short comment. I mean, it establishes a precedent. And so do we want to do that? It's certainly something that is worthwhile. And now we have language that supports those testing sites.
Wait, what
bad thing to do.
What's the precedent that
The precedent is that the General Assembly, through the ordinary budget process, the General Assembly, us, would be diverting from the recommendations that are made through the advisory committee on the opioid settlement. Just want us to be aware that we're doing that. It isn't something we shouldn't do or we can't do, but it is the first time that we've seen the funds. Okay.
Well, I would say, and I certainly cannot speak for the entire advisory committee, but I am a member of it. And this provision was discussed and made the list of the advisory committee, but we didn't put it in our final recommendations because of the immunity concerns. And we knew they needed to be worked out. We wanted things to move quickly. So I think this is consistent with the recommendations of the advisory committee. And on top of that, the General Assembly is granted the authority to appropriate funds of the state by the Vermont Constitution.
I did say all of that, and I agree with you 100%. I just want us to be aware that this is what we're doing. That's all. Boom.
Well, thank you.
Boom.
Yeah.
We accept that responsibility. That's all. All right, so here's what I'm going to suggest. We've got folks waiting to testify in our next set of compacts, and we'd like to hear back from Diva.
Andrea's back.
And Andrea, I don't think you've left. When you are ready to share with us, it would, thank you. It would be really helpful. Just communicate that with Alex and he'll give us a heads up.
I will. Thank you very much, Madam Chair.
All right, good. All right, terrific. Yes, sir.
Just a procedural question. Can this bill be voted on today and then the date be modified on the floor?
Well, we could, let's see where we get to. I mean, we may not have to.
But I do want to vote the bill today if we can.
I know that. So what we're going to do is we're going to move on to the next set of bills, and then we'll come back to this and we'll see where we are. we do want to vote. I mean, we could just change the date. I want to be respectful of the process that Diva's been talking about. Okay. So let's move on to our compacts. We have the psychology interjurisdictional compact, H282. We did go through it the other day with Jen, and we have Lauren Hibbert here and Lauren Lehman. We also have Marlene Marin. I'm going to suggest that we start with Marlene, and then we're going to go to Lauren. We've got a lot of compact bills, and Lauren, I'm going to look to you and Lauren to help us understand all of the bills together.
Madam Chair, I just add.
Yes. Sorry.
Bless you. There's 4 of these compacts, there's 4 fiscal notes and a memo summarizing the 4. I'll post on the website too.
Perfect.
So that will take notes.
All right. So, bless you. Sorry. Marlene, thank you for being here. Well, we're looking for your testimony on the compact. We don't, not necessarily going through it, but just your comments on the compact that would help us understand the need for this.
Sounds great. Right. Thank you, Chair Lyons and members of the committee for the invitation to testify. So for the record, my name's Marlene Marin. I'm the chief psychologist in the Department of Psychological Services at University of Vermont Medical Center. I've practiced in Vermont for over 32 years as a generalist and clinical supervisor, and I see people across the lifespan and specialize in medical psychology. I'm here as both a licensed psychologist and also on behalf of the University of Vermont Health Network to express our organization's support for H282. The goal of PsyPact is to increase access to mental health services provided by licensed psychologists via telehealth and limited in-person practice across state lines. It provides protection to the public by ensuring that psychologists meet acceptable standards of practice and that compact states have appropriate mechanisms to address disciplinary issues should they arise. Mental health services are limited in Vermont and elsewhere, particularly in rural areas and for underserved populations such as BIPOC and non-native English speakers. PsyPact increases capacity for culturally sensitive and trauma-informed care by allowing participating psychologists with specialized practice and expertise to serve Vermonters in and outside Vermont, as well as people in need of care elsewhere. The UVM Health Network serves patients in and from Vermont, New York, Maine, New Hampshire, Massachusetts, and afar. When people come to Vermont, they might be ill or injured. PsyPact membership would allow Vermont psychologists to seamlessly serve patients who enter the hospital system and to maintain treatment with them when they leave Vermont. It would also allow us to serve Vermonters who leave the state for a variety of short and long-term reasons like vacation, employment, military service, school or college, tending to family needs, relocation in general. Currently, if patients leave the state, psychologists can only provide telehealth services to them if they're licensed in each state in which the patient is physically located at the time of service. So I personally have temporary licenses and permits in North Carolina, Florida, Massachusetts, Pennsylvania, and I'm fully licensed in New York as well, only to be able to support patients and maintain my relationship with them when they are temporarily out of state or if they move. So maintaining treatment relationships, particularly for highly vulnerable young people, like trans young people when they go to college or leave the state for work, is not only clinically beneficial, it allows our patients to make use of their Vermont-based insurance, including Medicaid, by continuing with their Vermont provider. Vermont psychologists have greater capacity to build practices, thrive in Vermont, and contribute to our economy by serving Vermonters wherever they might be, as well as patients from other states who might require our specialized expertise. COVID taught us that telehealth is a highly valuable platform for providing essential mental health care to people who might not otherwise be able to come for in-person care. Access to telehealth has eliminated transportation barriers and costs for some and enabled immunocompromised individuals to participate in treatment. and it's been determined to be as effective and in some cases preferred over office-based care. Telehealth can be especially critical for patients with medical conditions, which require them to be out of state for stem cell, lung, or other organ transplants, or specialized medical and or other mental health, such as eating disorder treatment. Inclusion in SIPACT would help us to continue to provide support to them while they're not here, wherever that's appropriate. It's difficult to find and access psychological care in Vermont and across the country. SIPACT participation would allow Vermonters greater access to care and psychologists to serve Vermonters and others via telehealth and limited in-person contexts. The need for mental health services is increasing, and that's not likely to change anytime soon. SIPACT participation would help us to increase our capacity to serve those in need in a region that is desperately in need of resources. On behalf of my colleagues and the UVM Health Network, I do urge you to pass H282, and thank you for your consideration.
Thank you very much. And if you could, please send us your testimony in writing. You can send it to Alex and we'll have it on the record. Thank you very much.
Happy to do that.
I think it was clear in terms of out-of-state access. What is that? Okay, we're good. Thank you.
Okay, thank you so much.
Thank you. I know we have a lot of people signed up for, individuals signed up for each of the compacts. We'll try and get through all of their testimony. But Lauren, why don't you come up? They're all going to be up on the screen. So Alex, when they come, when our witnesses are in the waiting room, let them in and we'll hear from them on each of the bills as we go forward, so we can get that sort of fundamental testimony in. And then
Roger
we
that.
have, that would be great. And then Lauren
Of course.
is here. And Lauren is here.
Yeah, Madam Chair, is it acceptable to the committee if Lauren and I sit next to each other?
Of course, please.
We've been doing this pretty
It's a team effort.
Yeah. For the record, Lauren Hibbert, Deputy Secretary of State, and I have with me
Lauren Lehman, General Counsel for the Office of Professional Regulation.
Terrific.
So Madam Chair, what I was hoping to do was to give an overview of compact and compact law, why the Office of Professional Regulation supports compacts, and then we could dive into each compact individually, and Lauren can provide more detail on the logistics of each particular compact.
Okay.
Does that work?
That does work.
Okay. So, we will file testimony on all of these bills with a compact overview as well.
Perfect.
Compacts are an agreement between states. There's lots of examples of compacts. I won't go too deep into other examples, but a great one is the driver's license compact, which allows someone with a license from one state to drive in another state. It's a very similar concept with occupational licensure compacts, where someone with a license from one state is able to practice their profession in another state. They're very effective tools because they solve mobility challenges, they solve telehealth challenges, and they really allow for how people receive healthcare now. So the last witness just really clearly articulated that. They almost always have a revenue impact, so I would recommend that you review the fiscal notes. We have seen a revenue impact as a result of other compacts that we have entered, although as I've testified a lot this session, I don't think that that is a reason to not enter into an occupational licensure compact. I think the benefits of the compact outweigh the fiscal impacts of a compact, but it's just something that this body should really be aware of because it does have ripple effects if we move into many compacts or compacts that affect large populations. The fiscal impact is significant. And also we do have a small state factor here because we have a lot of people who live on the border of another state. If that provider in New Hampshire does not need to get a license in Vermont to provide care to the Vermonter located in Whiteford Junction, it's just we have a lot of borders and we have borders with significant states. So we also are very cognizant of the effect of compacts on the enforcement process. We always in Vermont maintain our ability to enforce our disciplinary standards against somebody who's practicing in our state, whether they're physically practicing in our state or practicing via telehealth on a Vermonter in our state. We have jurisdiction over that individual. And the complication there is we may or may not know their home address. We may or may not know how to contact them because they're licensed in another state. So there is some complications in enforcement. We have really worked through a lot of those with the nurse licensure compact, not unsurmountable, but there is an effect. And it also, we have enforcement costs, even though we're not receiving licensing costs. So when you're thinking about the fiscal impact, we still have to do enforcement actions over somebody who's never paid a licensing fee here. We are very cognizant at the Office of Professional Regulation and the Secretary of State's office about the impact of our world post-Dobbs. The compacts frequently specify that if a state in a compact disciplines a licensee, the other states must also discipline or restrict that person's ability to practice. We worked on working with the Interstate Medical Licensure Compact on a workaround rule that would we would have to immediately suspend the compact privileges of somebody, but we would be able to also immediately issue a single state license to somebody who was disciplined in a state for providing abortion care. We're really cognizant with the compacts before you today of that issue. We think there's benefits to joining the compacts at this time, and I'll let Lauren explain that because these compacts are at different phases in their implementation, and we as a state would really like to be on the ground floor of the compact rulemaking and, as possible, implementation. So for instance, Lauren has been on the social work drafting compact committee that has just been done. We're very grateful for her smart brain there, but she's able to, by being part of the drafting, she's able to craft some of the rules of the compact to accommodate the fact that we're now in a post-Dobbs world. So for the compacts here today, obviously, we think that post-Dobbs, we're really concerned about abortion providers and gender affirming care. So that's very relevant for the psychology compact, the counseling compact, and the speech language and audiology compact. That compact, it may not come as immediately to mind, but they do provide gender conforming language to help people transition their voices. So it's really important to keep those things in mind. We don't see it as much an emergent issue in the PT compact, but we are going to make sure that we don't, 18 months ago, the compact world was not anticipating this was going to be the hot button topic either. So we're going to pay attention to it in any compact that we enter into.
And so we've talked about that a little bit in this room, and whether or not we need to add specific language in each compact, but rather we've already put language in that directs our compact negotiators to build that. So is it necessary from your perspective?
I don't think so. I think the language in S37 will cover what is necessary, and we actually, even on the House side, have made a little tweak to that just so this committee knows, to make it clear that the negotiators for the compacts need to seek to change the compact rules. So even a little bit more clarity there. But we don't think that any language needs to be added to each of these bills. We think it's better to have it as an overarching principle in S37.
Okay, thank you.
So I'll walk through each of the compacts and detail just how they work and how they function and are administered. I can go fairly quickly.
Do you want her to go compact by, do you want to do like one compact and then witnesses for that compact, and then another compact and then witnesses for that.
Since we have witnesses, that might work. As long as we have witnesses coming in, I'd like to make sure we get their fundamental their testimony, because I know we probably can get your access is greater for us. Yeah, okay. So would be, are you gonna start on 282 or?
Yeah, happy to do that. So the 282 is the SIPACT, which is the Psychology Interjurisdictional Compact. It's probably one of the more complex compacts and more limited in effect. It through a series of licenses that an individual obtains, they'll be allowed to practice telepsychology or practice for 30 days in another state in person. There's 2 levels of licensure. The individual, 3 levels. Individual needs to get a home state license initially. Then they need to go to what's called the ASPPB, which is the Association of State and Provincial Psychology Boards, and get a for the telehealth for telepsychology an e-passport. That costs $400 at this time. And then once they've obtained that e-passport, they have to go to the Compact Commission and get a authorization to practice telepsychology in another state. And once they've obtained those 2 things, which need to be renewed annually, in addition to their home state, they can practice telepsychology elsewhere. Alternatively, if they want to practice in another state for up to 30 days a year, they can again go to ASPPB, get an interjurisdictional practice. I'm buffing the names, but they get one type of license from the ASPPB, an interjurisdictional practice certificate, and then once they've obtained that, they go to the commission and get a temporary authorization to practice from SIPACT. And again, that's in addition to their home state license, and it just authorizes 30 days a year. So it's a little more complicated than most of the other compacts where you just have to get one additional license or even no additional licenses. And so it's limited to those psychologists who have a doctorate degree from an APA accredited program. So it's got limited number of people and limited authorizations. That's both beneficial in the sense that I don't think we would be losing Vermont psychologists to the compact because they would just move to another state or just change their practice to be all out of state. But at the same time, it also limits like how much, and I think it would facilitate some interstate, as you heard from previous witnesses, some telepsychology, be able to follow the patient out of the state, have specialists from other states treat Vermont, for other member states treat Vermont patients. So there are some significant benefits. It's just more limited in impact. So that's
we have all your testimony.
Well, yes, we'll submit it.
Oh, we're good. Good. Yeah, it's good. I remember when Jen went through this compact with us, it did seem like there were more pathways to take than the roadmap seemed full of different layers. Okay, thank you. Questions? All right. So we have H62, which is the counseling compact. Perhaps you could talk about that, and then we'll go to Melissa Willett, who is with us on the screen.
Absolutely. So right now there's 16 states, including New Hampshire and Maine that have adopted this compact. We think this is a significant benefit in the sense that it's very, the requirements for getting a clinical mental health counselor license, which is students of FACS, licensed professional counselors or licensed mental health counselors, clinical mental health counselors in Vermont. The requirements for licensure change from state to state because there's not universal accreditation of the education. And so it could be very hard to move from state to state and ensure that you can keep your license in that other state. This would facilitate that. It is in its early stages. Only 16 states have adopted so far. It was 10 states needed to adopt to trigger the establishment of the commission. So right now there aren't any privileges being granted, but they anticipate they'll start issuing those privileges in late 2023 or early 2024. Again, it would be, as Lauren noted, a good time to get in the commission and have
some impact and input on those initial rules for implementation. This is a privilege-based compact, which you'll see in both the ASLP, the audiology and SLP compact, and the PT compact, which means the individual gets a home state license, and then they apply to the commission for a commission license. And once they've, or a compact license, once they've obtained that compact license, they say, I want to work in X, Y, and Z state. And the compact says, great, pay us a fee. And then here's the state fee for each of those states. I believe the fiscal note addresses what the state fee is. I believe it's $50 for that state fee. So if they say they want to work in Massachusetts, or New Hampshire, Maine, and Vermont, they get $50, pay $50 for each of those states. And then Vermont gets that $50, and we get notification that person's practicing here, which is helpful for things like enforcement. So we appreciate this structure. I think, and again, with access, there's always questions. So you might be getting some in, but you're also probably losing some. You're probably losing some borders. So there will be a fiscal impact. It does facilitate interstate telepsychology, so you're getting more. And there's been some concerns the boards have expressed about somebody practicing telepsychology from another state, knowing what the crisis resources are in Vermont, ensuring that if somebody's in crisis, they can refer them to a place to get in-person care. So those are the concerns, but as Lauren said, we believe, OPR believes that the benefits outweigh the challenges here, and in this situation, we can mitigate a lot of those challenges.
Thank you. And so other questions on that? That's very clear. This is a good way to look at all of them. Melissa Willett is here to testify. Melissa, were you going to talk about more than H62? I see that there's testimony from you on a number of the compact bills.
Yes, my testimony is specific to H62 as it relates to the counseling compact. But my comments generally would align also with the other three compacts that the Department of Defense supports.
Good. So why don't you go right ahead with your testimony? Thank you.
Thank you. Good morning, Chairwoman Lyons, Vice Chairman Weeks, and distinguished members of the committee. I am Melissa Willett, the New England Region Liaison for the United States Department of Defense State Liaison Office. And I join you today to testify in favor of the policies reflected in House Bill 62, which addresses licensing issues affecting our service members and their families. There are many unique requirements that come with a life of service in the United States Armed Forces. Those responsibilities are not only bestowed on the service member, but also on the spouses and children of those actively serving our great nation. The Department of Defense understands the challenges that oftentimes present themselves to military spouses, and reducing those burdens is a priority of the department. The annual percent of the military spouse population that moves across state lines is 14.5% compared to their civilian counterparts at 1.1%. As much as 34% of military spouses in the labor force are required to be fully licensed, and of those spouses, 19% experience license maintenance difficulties. For military spouses, professional licensing requirements remain an enduring challenge. Due to the nature of the military, most active duty service members change duty stations every few years. Not only is the service member expected to reacquaint themselves with a new installation, unit, and command, the spouse too is forced to reinvent themselves professionally. The Interstate Counseling Compact will allow counseling professionals to transcend these boundaries. Frequent moves and cumbersome licensing or certification requirements limit career options for military spouses. Removing these barriers, creating reciprocity in licensing requirements, and facilitating placement opportunities can help a military family's financial stability, speed the assimilation of the family into its new location, and create a desirable new employee pool for a state. To address license portability for military spouses, states have turned to occupational licensure interstate compacts, which streamline licensing between member states of a compact for all practitioners in an occupation and provide specific support for military spouses of relocating active duty personnel through provisions recognizing unique requirements of military life. This is significant for the military community in that along with active duty military spouses receiving the benefit of compacts, active duty members, members of the reserve component spouses, transitioning service members, and other veterans benefit from the mobility provided through the compact. To date, 16 states have signed the counseling compact into law. The compacts have the potential to significantly change the way counselors can practice and will provide continuity of care as well as the ability of counselors to reach underserved populations. Vermont, very much a rural state, could benefit greatly from the policies outlined in the compact. If passed, the policies reflected in this legislation would preserve Vermont's authority to regulate the profession, but the overall opportunities and quality of life for both counselors and clients could be amplified. When looking at the reasons many service members choose to don the uniform, many will tell you it's for family, community, and country. Military service, however, can only continue with the support of that family in their times of need, to include professional development and security. The Interstate Counseling Compact, while vital for our communities, is also critical to the mission of the Department of Defense and the overall retention of our military men and women. Lastly, the Department of Defense is also in support of the 3 additional compacts being heard in this committee today: the Psychology Interjurisdictional Compact, the Audiology and Speech Language Pathology Compact, and the Physical Therapy License Compact. With the above stated benefits in mind, we look forward to engaging in efforts that will create increased quality of life for all populations we aim to serve. Vermont's military veterans, service members, and their families make significant contributions to our communities and our workforce, and the Department of Defense remains committed to working with our partners on the local, state, and federal levels to recognize the sacrifices they make on our behalf. On behalf of the Undersecretary of Defense for Personnel and Readiness and the Deputy Assistant Secretary of Defense for Military, Community, and Family Policy, as a service member and military spouse myself, I am grateful to the committee for your work on behalf of those who have served and continue to serve. I thank you for your time this morning and look forward to the positive outcomes of these policy changes.
Thank you. We do have a question for you.
Thank you, Melissa. Certainly understand all the challenges for military spouses during the career movement of their spouse. My question is, as you know, there's a significant military presence overseas. So we're not just talking about stateside, potentially stateside compacts. Do these compacts or any compacts include Department of Defense facilities which are outside of the U.S.?
As long as, oh, I'm sorry.
No, I'm sorry. Go ahead, please.
As long as the spouse that's looking to practice in a compact state has a professional license from another state within that.
But I'm not talking about states, I'm talking about overseas. So just curious if these compacts extend into DoD facilities which are not stateside, they're overseas.
No, sir, these are stateside compacts.
Thank you.
We do have one compact that referenced interjurisdictional. I'm trying to remember which one that was. It could have been counseling.
They're all interjurisdictional, but they define jurisdiction
But they
as
had
state.
state.
Okay.
Or other.
Thank you. Yeah, that was a question that we had. We were thinking Canada at the time, but it could be England or. So actually, that testimony takes us to the end of H62. Before we dive into H86 or H77, I see that Andrea is back, the Commissioner of DEVA is back, and I'm wondering if there has been we can get some resolution to the question that we had on dates. Andrea, are you available there? Good, thank you.
Yes, thanks, Madam Chair. I did actually get back in touch with Commissioner Levine and some of his staff. I also spoke with some of the DEVA staff. So where we landed as a group, and I don't know if David is in the room, but he may pop back in if he's not. Where we landed as a group, I'm sorry.
He is here.
Okay, perfect. I'll let him speak to the Department of Health components, but in terms of the Department of Vermont Health Access, we can reprioritize staff time. There are a number of operational changes that need to happen in the pharmacy as well as the drug preferred drug list. And we can do that for January 2024. My understanding is that the Department of Health can also reprioritize their staff time because the burden of education policy procedure updates falls heavily on their group. So let me just let David speak to that aspect.
All right, thank you. Thank you for your diligence and work on that.
Thank you,
We
Commissioner.
Appreciate it.
Thank you.
David Ingram, Department of Health Department can allocate these resources to make that on January. 2020.
So we said January 1st.
January 1.
Okay. Where's Katie?
She had to go upstairs, I will email her.
Okay, very good. All right, good. So I would do want to come back to this because we want to vote on the bill, and I think that was the last big piece. So we do appreciate very much the work that you're doing on that. And we also do understand that getting the educational piece out is critically important. We don't want to have a failed medical system and professional dissolution with this at all. So we appreciate that. Thank you. So we're good. Thank you, Commissioner.
Thank you very much, Madam Chair. Thanks to the committee, and I will sign off.
When our Ledge Council returns, we'll get that back in and we'll look at the whole amendment for a possible vote. Terrific. So let's move along to H86.
Sorry. Figure out which one that is. Yes.
Okay, which is speech and language pathology. We do have Melissa Clark is already here, so after you've gone through, we'll hear from Melissa.
Thank you. Lauren Lehman, OPR for the record. So this is for audiologists and speech language pathologists. We currently have, those are two separate licenses that the Office of Professional Regulation offers, but they're combined here in this compact. There are currently 23 states participating in the compact, including New Hampshire. They, just like the counseling compact, just reached that kind of threshold level of states to convene the commission last year, but they're a little bit further along and they hope to start issuing privileges this year, probably this summer. So they're a little bit further along, but are not yet issuing privileges. So we support this generally. Of course, and it's the same structure in terms of privileges and getting a home state license and then going to get the compact privilege and then notifying other states that you want to work there. Again, it's $50 for that. We've asked for $50 in the legislation for the state fee. There's a couple of complications with this one, but not insurmountable. This puts the burden on the state to ensure that the audiologist or SLP meets the requirements for the compact licensure before issuing a state license. Because there's different requirements for the audiology compact license, we would need to develop a new license type for specific to those who are qualified for the compact license. We might be able to do it through a specialty or some sort of other issuance. Once they have that home state license, they can then go to the compact license, but usually it's the compact will confirm that you're qualified under your home state license. In this one, Vermont needs to confirm you're qualified before they go issue the home state license and they go to the compact. It's just a matter of audiology degrees in that situation. Vermont allows master's level audiologists to obtain a license, and this requires a doctoral level degree. It might be a distinction without practical effect because I hear that there are no longer a lot of master's audiology degrees, but just in terms of consistency with our state law, we likely need to create a separate licensing function in order to ensure compliance. But again, not insurmountable. Same complications and benefits that the other ones have. You know, it provides mobility. It may improve access. It may not improve access. We would need to make clear that in order to work in a school, the SLP, even here on a compact license, would also need to get a license from the Agency of Education to work in a school environment. We could easily do that. Have that communications now. And And then, of course, as Lauren noted, there's the reciprocal discipline component where somebody's disciplined in another state for providing, in their home state, for providing gender affirming care, abortion services, gender affirming care in this situation. They would, under the compact agreement, Vermont would need to remove their compact license, and that would require us to prosecute basically under another state's laws to remove that license. But this can be addressed through rules making, and we would, under S37, the state delegate to the commission would need to address those complications.
And Madam Chair, if I can, the state delegate would be Lauren Lehman.
Yes, I would be the delegate.
So.
Okay.
That has come up as a question just in general, the state delegate for all of these. Are you the state delegate for all?
Me or one of my staff attorneys would be the delegate. What they ask is that somebody from the Office of Professional Regulation be delegated. So that would be me.
Okay.
Yeah,
that sounds like fun.
and apparently the master.
I need to get you a hat or a badge or something.
Like a hat.
What it does do is it means that it's the benefit of being a small state and a small umbrella organization, is it does mean that Vermont is going to approach compacts in a uniform manner and in a way that's informed by how other compacts are dealing with this very complicated interstate federalism versus states' rights issue. And I think the reason why I mentioned it is I do think this should provide this body a lot of comfort that there's someone who's employed by the state who's going to be doing this, and it's not an appointee of the governor or the secretary of state that's making these decisions.
Okay. Any other questions? Let's see, we have Melissa Clark. We also have Susan Adams here. So Melissa, we'll begin with you. Thanks for being here.
Yeah, thank you for having me and hearing our testimonies today. This is something the Vermont Speech and Hearing Association's been working towards for over 6 years. It's been on our agenda, and our professionals in the state find it to be a really important matter. So we appreciate your time. So just to give you a little bit of background about myself, I'm an audiologist and I practice in Middlebury, Vermont at Porter Medical Center. I also volunteer with the Vermont Speech and Hearing Association. I'm the current membership chair and have co-led advocacy affairs with an SLP Sierra Downs. And I also volunteer with the American Speech and Hearing Association on the Committee of Ambassadors, where we advocate for important public policy agenda items. So today, we're of course talking about the Interstate Compact, which has been on our radar for quite some time. And as far as some data that we've collected for VISHA, we've sent out surveys to our association members and professionals, and consistently when we send out surveys, greater than 80% of the people find this to be an important to very important matter. So it's consistent across the board that folks are really feeling overwhelmed, and they're hoping this to be a way to bring professionals to our state, not only because they're overbooked, but also because our folks in the state are not being served in a timely manner. At the national level, they've done lots of surveys as well, and it consistently shows that there's funded unfilled positions. In one of the more recent ASHA surveys in New England, it was really just across all of New England states, there were 36.6% of respondents that reported funded unfilled positions in their workplace. So I think that just shows the need that we're in right now to have professionals come to our state to provide services, and shows that there aren't providers here for people to receive their services. So it's really a two-way street with the professionals and all of our patients that have needs that aren't being filled. So when we're looking at the Interstate Compact, this is probably pretty consistent across compacts, but there are a lot of variances with state licenses. So this is one of the things we're hoping that if the licensing process is streamlined, then maybe people will come to our state. So things that can vary with the audiology and speech language pathology licenses include the number of continuing education hours you have to take, the certifications you need to apply for state licenses, And there's a couple of other things also. And I can say, as being part of the VISHA board for so long, one of our most common questions is in regards to licensing. And I think, our state has probably a little bit of an easier licensing process than some of the other states, but it is definitely one of the most common questions we receive as our state board. So I thought, that would be a good piece of information to share. So, hoping that becoming part of the compact will really streamline the process, open the doors for professionals to reduce workload. That will be really important. I do have a parent story that was just happened 2 weeks ago. So there's an audiologist in Rutland, and she knows, oh, it looks like my.
It's okay. Keep going.
Oh, like it. There we go. So there's an audiologist in Rutland, and she reached out to the VISHA board because she has a daughter needing services through early intervention and has been on the list for over a year without receiving an assessment and services. So she's now ended up reaching out to a private practice, driving over 2 hours, but she shared the SLP at Rutland Regional Medical Center has over 150 kids on her wait list needing to have an assessment and have services. And at that number just really blew my mind. I mean, 150 kids that are age 3 or less needing to be seen.
Uh-oh. You're frozen, Melissa. Yeah. Okay. Thank you. If she comes back, we'll return to her, but
Does she have written testimony?
She hasn't sent her.
And I testified the intervention, never received assessment or services. So it just shows the dire straits that our state is in. I hope that came through. I'm sorry, it looked like it was freezing up there.
Melissa, you're going in and out. I'm going to ask if you wouldn't mind sending your testimony in writing to Alex.
Yes.
That'd be great.
Thank you. I apologize that the connection seems to be unstable.
It's not your problem. It's the internet connection problem.
Yes.
That we all have. Yeah.
Well, thank you again for hearing me today, and I will definitely write up my testimony and send it right along.
Thank you so much.
Thank you.
And Susan Adams is here. Thank you, Susan. So let's hope that we don't have other difficulties. There you go.
Thank you, Chair. Hopefully we won't have any of those issues on my end. My name is Susan Adams, and I'm the Director of State Legislative and Regulatory Affairs for the American Speech Language Hearing Association. I'm also ex officio to the Audiology and Speech Language Pathology Interstate Compact Commission's Executive Committee. As you know, ASHA is the National Professional Scientific and Credentialing Organization. We currently have over 228,000 members, and we have 560 members in Vermont. So you already know this legislation is in its simplest form is both a compact and a contract between states to just recognize another pathway to practice. The compact has now passed in 26 states. We added Arkansas, Virginia, and Washington so far this legislative session, and we're awaiting Montana's signature also. So that will take us to 27 in total so far. We also have 14 other states that have pending legislation. So the compact is just designed to allow audiologists and SLPs to practice across state lines and through telehealth, both legally and ethically, without having to obtain a license in every state and instead getting that privilege to practice. It's going to help us increase access to care for those with communication disorders, facilitate continuity of care when clients relocate or travel, and increase consumer protection by expanding the prosecutorial net for bad actors. The compact will allow greater access to currently underserved populations and isolated populations, and it will also support military spouses. I know Melissa Willett from the DoD is on this call also, and she might be able to share more of the DoD support. The commission is currently coming into operation. They have established, as I mentioned, committees and are adopting rules and bylaws for the compact to run. They're also working with vendors to create a database to begin issuing privileges. And this is where we might be able to work with the state to make it easier for Vermont to figure out who is eligible for the compact and who is not. That system, as I mentioned, is not yet created, but we're hoping that it will be operational by next year. If the state were to adopt this legislation, this legislative session, you would be able to immediately appoint your delegates to the commission, and they would be part of the decision-making process that the compact goes through with the database, the rules and the bylaws. I hope we can count on your support to move the bill forward and increase access to care for the residents of Vermont with communication disorders. And I'm happy to answer any questions that you may have.
No, thank you very much. Thanks for your work. It is challenging. We understand that. We appreciate what you're doing on both fronts. Great. Questions? Okay. All right, good. Sierra or Linda? Linda. There you are. Yes. Would you mind, and we'll let Linda take the seat, and then we're going to move on to H77. 222.
Okay, I'm not sure. Not sure. Do not have to name it on this.
I don't think we were all. Yeah, you're relieved. Relieved duty. Thank you for being here.
Thank you for inviting me. I really appreciate the opportunity to come and talk with you. My name is Linda Hazard. I'm an audiologist. I have been an audiologist in the state of Vermont for 42 years. So a long time. So I've seen lots of changes, lots of opportunities, and lots of challenges along the way. Additionally, I have a doctorate in educational leadership and social policy from the University of Vermont, where I worked closely on education issues as well as audiology issues during that doctorate. So I'm the current program director for the Vermont Early Hearing Detection and Intervention Program. I oversee early intervention services for deaf, hard of hearing, and deaf-blind children in the state of Vermont. And I also oversee some of the school-based services, particularly around ASL, bilingual approach, direct instruction with teachers of the deaf for our deaf and hard of hearing population. And I also serve on 2 governor-appointed boards, one for deaf and hard of hearing and deaf-blind, and one for children's integrated services. So today I'm here to testify personally, though. And from my lived experience as a provider in Vermont since 1981, I fully support this compact for audiology and speech and language pathology, as I firmly believe that it will provide the opportunity for additional qualified professionals in our state. I have had recently an open position for over a year for a speech and language pathologist, and I'm happy to say that we filled it 2 days ago with a speech and language pathologist coming in from Pennsylvania, very much wants to live in the Bennington area of Vermont. So we were excited because it's the perfect setting. So
congratulations.
Thank you. And it has been a long process, trust me. There are many challenges and opportunities that we face and that you've heard spoken about recently, in recent testimony. Nationally, more audiologists are retiring than are entering the field. We have a shortage of qualified pediatric audiologists, and that is across the nation. It's not just in Vermont, but it is something that we are all trying to address. The early hearing detection and intervention national goals are every state and territory has someone who is overseeing that program. It is to ensure that infants are screened by 1 month of age. They are diagnosed with hearing loss by 6 months of age and into early intervention by 6 months of age. Currently, there are long waiting lists for services. I will say that our pediatric audiology sites, which right now are Burlington, Rutland, and Dartmouth, they are priority. They do, try to, ensure that these babies are receiving those services as quickly as possible. but it's still a tough environment.
Yeah.
The HRSA, Health, the Health Resources Services Administration has also asked Eddie Programs to come up with a plan due in 2 weeks for how we can screen babies up to age 3, because in our state and nationally, there are 1 to 3 babies diagnosed with hearing loss per year. And that triples for infants age 6 months to 5 years of age. So finding a way of also initiating screening, which means we will need more audiology support. We do not have enough speech and language pathologists, as Melissa mentioned. There are 79 infants right now waiting in the Burlington office for speech and language evaluations, which is something our program is hoping to be able to help. And that does not include the services that will be needed after the evaluations. And it's also very important for those birth to 3 children to be evaluated for hearing, because speech and hearing issues go along with hearing loss as well. We also have a shortage of listening and spoken language services. The compact would allow for sharing of resources between states enrolled in the compact, allowing for more provider availability. Audiologists and SLPs would have 1 license. Again, Melissa mentioned the issues of licenses, in more than 1 state. We have providers right now that have licenses in more than 1 state, along with CEU credits. This allows for creative solutions of ensuring that the needs of children and adults are met here in our state of Vermont. So thank you for your time and for listening.
No, thank you very much and for your work. And I used to travel with my husband to Rutland, and then we'd go to Brattleboro, and we'd go to Bennington for hearing tests and working with kids.
Yes.
And it's a lot of work. Thank you.
Yes. Thank you.
Senator Bullock.
Thank you for your testimony. I have a quick question.
Yes.
I'm excited about these compacts. It just seems like hopefully it will ease the burden that we're feeling in the state. But at the same time that I'm excited about the compacts, I keep hearing about how we are short of medical professionals, not just here in Vermont, but nationwide. And so I guess I want to hear some assurance that this is going to help in spite of the shortage nationwide.
I believe, as a provider, that it will help, because I think it will give flexibility to providers to be able to work, between states. And that has always been a challenge for us. And part of it is the financial and the CEU requirements. So I do believe we can. And I'll tell you a little bit about some initiatives, although not necessarily related to speech and language pathologists and audiologists, but in relation to teachers of deaf and hard of hearing. We have been looking and working closely to bring what we say, to grow our own, because sometimes providers, especially in those areas, may move into Vermont and then say, oh, it's cold here. So we've been really trying to encourage our teachers to become teachers of deaf and hard of hearing, and we did help fund 3 of those positions this year. I do think the same is true of audiologists. We will want to, I think about going to high schools and talking about audiology and the importance of the field, and also encouraging our students to graduating from Vermont high schools to go into the field of audiology or speech and language pathology. I do think that this will ease the crisis that we feel, because we'll have more flexibility with providers from outside of Vermont as well.
Thank you. Senator Williams.
Thanks for your testimony. I'm kind of curious about patients that they don't have to be referred by a primary care physician. Is there going to be a registry of audiologists? How are we going to get in contact? How are we going to know who the best?
As far as referrals, that's a really good question. The Vermont Department of Health website, although it is our children, does have a list of audiologists. Mm-hmm. And I believe also, and if not, we will make sure that it is on there, is the Dale website.
Okay.
Because the councils, the Vermont Deaf, Hard of Hearing and Deafblind Council sits under Dale. Mm-hmm. And that's a really good suggestion to make sure there are audiology lists to help, Vermonters know where to go. And I think there are other places too that we can look to ensure that we.
You have snowbirds going to Florida and they don't have to stay in network. How are they gonna know, if they're somewhere in between, how to get some help? And maybe, I don't know, does the Secretary of State's office keep track of all these?
Just left.
Yeah, I know.
Oh, Lauren's here. Oh, I didn't. You were hiding.
So you're gonna have them registered on your website?
For these, for audiology, it's speech language pathologist.
Yep.
Yeah.
Okay.
So I think it's a combination of making sure it's as many places as we can.
Mhm. Great.
Thank you very much for your
Thank you.
time.
Thank you. It was terrific. So we're going to look at H77, which is the physical therapy licensure complex, briefly with Lauren. And then we'll be moving back to 222.
So, thank you, Lauren Lehman, with OPR for the record. Right now, my numbers are 33 for 33 states. As was just noted, I haven't checked in a couple weeks, so things may have changed based on other states' legislation. New Hampshire is included in that. OPR is supportive of this fully. We don't see as many complications here. It allows physical therapists and physical therapy assistants to work interstate. There's the impacts mobility, again, is very helpful. As you've heard today, one of the barriers with getting a license in multiple states, you have to do continuing education in each of those states of licensure, which can really add up. And there's inconsistent requirements. So this would eliminate that requirement. You just have to do continuing education or continuing competency in this field in your home state. It's not sure, again, as I think you just noted, Senator Gulick, that you might have influx, but you might have outflux as well. And but hopefully there'll be, especially with telehealth services, there'll be greater access. And we do have funding for it. One component that we didn't address here in the House and we've just been made it kind of aware of is that we have to modify our Title III to permit background checks of these professionals, because that's one of the qualifications to obtain the compact license, but we have not historically required that for Vermont licensees. We had added in the House bill physical therapists. We should have also added physical therapy assistants. So we will submit recommendations and work with Ledge Council to make that modification if that's acceptable.
Is it, excuse my ignorance, but are acupuncturists involved in this? Aren't they part of physical therapy?
They might be involved in a physical therapy practice. I know physical therapists are authorized to provide what's called dry needling, which is comparable to acupuncture, but they're not implicated in the compact.
Okay.
They would not be included here.
Not even if the physical therapist they were working with was?
Yeah, no, it would just be the only individual authorized to engage in interstate practice would be the physical therapist or the assistant who holds one of those interstate licenses.
Thank you.
So that's all my.
So the question about background checks is only specific to the compact. Okay, so I want to be clear on that. It's not, doesn't expand it into the state for a new requirement for licensure.
It could, it's leaves it up to a policy decision, really. Title III would authorize OPR to conduct the background check. With other professions, we've made the decision that we should expand it to all of those professionals, regardless of whether they're seeking an interstate license or a home state license. We obviously would take guidance and feedback on that and what the preference would be, but we wouldn't necessarily narrowly tailor it just to the authorization in Title III would be for any PT or any PT assistant applying for a license. And that would, and once we guaranteed that, then that person would be eligible to get the multi-state license.
Okay, so why don't you work with Ameren on the language and then we're going to have to review it. Okay. Yeah, we will look at it. It's not, it's not a trivial, not trivial by any means. Thank you. Yeah, thanks. Okay, that's good. So I think we'll end our compact discussion now. We will come, the next time we come back to the compacts will be an opportunity to vote on the compact. All right. So good.
Thanks, Lauren.
So all I need is Katie. Alex, can you we're gonna go offline for a minute while we